The theme for this year's TEDMED event is When Poverty Becomes Disease. Can you talk more about the link between poverty and health outcomes?
Thank you very much for the introduction, and it's a pleasure to be here. So the question is, what's the link between poverty and health outcomes? And I'm going to address this point from a research perspective, because that's what I do. There's overwhelming evidence of this connection, which you're all probably aware of. And when we think about this as researchers, we're really, it's interesting to draw the connection and the correlation between these two, but when it comes to prevention and intervention and identifying policies, what we're really trying to do is identify mechanisms that connect poverty to health outcomes. And I just want to talk about 4 ways that are documented in the research. The first one is really about health access. So we know that people who are in poverty have less access, and this less access leads to lower outcomes. So poverty and health outcomes are connected by differential access. The second one is environmental health factors. So these things can help explain various health disparities across poverty. So we know, if we think about we know that poverty is geographically concentrated, and in those geographic concentrations are higher levels of exposure to environmental toxins and so on. The last 2 are kind of more social things, and the third one is violence. We know that people who are living in poverty are more susceptible and more exposed to various forms of violence, and this affects the human development in various ways, leading to health outcomes. And related to that, but different, is stress. So that's the 4th thing. The 4th mechanism is stress. We know that people who are living in uncertain economic times, living in poverty, living close to poverty, there's economic strain and stress that affects the family, also translates from parents to children, and then ultimately leads to poor health outcomes. There's a lot of emerging work that many of you are probably familiar with on the toxic effect of poverty on the brain and so on. Those are 4 mechanisms. I think I would add a 5th, that there's a lot of unexplained things that we don't know right now as we sit here today, that research is on the forefront of trying to identify different mechanisms that shape this relationship between poverty and health.
Great, thanks very much. Next, I'd like to go to Dr. Schmidt. So over the past 6 months, our country has experienced several natural disasters. As someone who has been deployed and responded to these emergencies, can you tell us more about poverty, disasters, and how we can better prepare as a community?
Well, I too can be a researcher, but I'm not going to be today. We're going to practice our imagination. Imagine as you are, you're sitting here right now, and the 9.0 earthquake that could happen here happens. The building's shaking, things are happening, we all run outside. Now what are you going to do? Suddenly, you have no communication, your cell phones don't work, the internet doesn't work, the roads are blocked, you don't know where your family is, you don't know what to do. What are you going to do now? That's what it was like the morning after the storm in Puerto Rico. Now, imagine that it's not you that's sitting there, but it's the person who lives in transitional housing, who has no access to resources, who doesn't have a car, doesn't drive, doesn't have friends, doesn't have any place to go, doesn't know what happened. What resources does that person have? Are those different? So I think that there is a difference between poverty and us well-to-do folk. Or imagine after Katrina, people said, we're going to evacuate because we don't think the city is going to survive the storm. If you live on the streets and don't have access to a car and don't have anywhere to go, How do you get there? How do you travel? Just saying evacuate is not a plan, which is actually what they did. Further, the 9th Ward is below sea level. Do you think that rich folk live in the 9th Ward? No, the rich folk live on the hills where their houses didn't flood, where the levees didn't break. In Houston, it was the areas that were most impoverished that had the oil tanks and the chemical plants next to them. In Haiti, after the earthquake, there was massive devastation throughout Port-au-Prince because of the way the buildings were built and the poverty. But the U.S. Embassy, which is in the center of the area, was literally undamaged except for a few fancy plates that fell off of shelves because it was built to earthquake standards. So there is a difference between poverty and wealth in terms of how it impacts disasters. So, have you figured out what you're going to do? Do you have a plan? How are you going to find your families? Are you going to go to work? Can you get across a bridge? Does your health department have a plan? Does your fire department have a plan? Who's going to come to work? Who's going to find your children? I think we are all obligated to develop plans so that we can both protect ourselves, our families, and be able to support our communities. And as our communities plan, as our health departments plan, you have to assume that half of your workers are not going to come to work. Because if you had to figure out where your kids and your husband were, or where the rest of the community was, where would you go? What about your sick cat? What about crossing the bridges? All of these things need to be taken into account when we plan for disasters.
Great, thank you. The next question is for both Deborah and Emily, and I'll go ahead and ask Deborah to respond first. So you two work, your focus of your work is on providing services to people living in Clackamas County. Can you each share some of the needs and demands for services that are occurring locally?
So that's a pretty big question. It's fairly loaded. But I would say, as a nonprofit that offers services and basic needs, those are always on the rise. In 2016, we saw an increase for the need for food, for groceries, increased by 21% over the course of about 9 months. The last time we had an increase that large, it took about 5 years. So I do think that there are just a lot more folks being pushed into a position of need that weren't there before. So, yeah, those kind of services the demand is growing. Food, clothing, just the basic needs, healthcare. In terms of the needs, though, I think that we're understanding the need a little bit differently as of late. I think there's a need to create more spaces and services that address the trauma of poverty. Certainly people that are living in poverty, living outside, are experiencing trauma every day. And that has an effect on their physical health and their mental health. And so as we move forward as a center, we're really looking at ways to provide the services, the basic needs that we know people are going to need. That's not going to change. But providing them in a way that's more trauma-informed, that really addresses the day-to-day that folks are living in. And so I think that's something that we as an agency are seeing the need for.
Great, thank you. And Emily, with the food bank perspective.
Thank you. Yeah, like Deborah said, there are a vast number of needs that we are seeing people have in our community. And being somebody that works with the food bank, I do work with partner agencies who are distributing food in the area. And when I go out and visit my partner agencies and talk with my organizations that are distributing food to the community in Clackamas County, we always talk about accessibility and how that's a big barrier for people here. And Dr. Rothwell touched on it a little bit. And it's a big issue here. We have a lot of folks living in the rural communities, and accessibility is difficult. And And so at the Oregon Food Bank, currently we're working on a project to identify underserved pockets of the community, specifically in Clackamas. And by doing this, we think we're going to be able to come up with some better solutions on how we can serve those people. And Clackamas County, we're hoping to pilot that project in Clackamas because, as I know, we are number 2 in meals per person in need. And so we're really going to be focusing on that in the next few months. We're excited.
That's great. Yeah, Clackamas County is huge geographically. Our transportation system can be limited, and getting the resources to people where they live can be challenging. I'd like to go back to Dr. Rothwell. So as someone who runs a number of programs that have eligibility requirements, some of which are determined by the poverty level, it's clear to me that many people who have incomes above the poverty level still struggle mightily every day. So I'm interested to hear more about your work and how different ways that we can measure poverty in our community.
Okay, so that's something we could talk hours for, especially.
We have about 4 minutes.
4
so,
minutes, okay. So I'll just try and, I'll mention a couple things. So we're working on ways to measure poverty, not based on household income, but instead based on assets, net worth, and debt. That's one area. Perhaps more important and a more locally relevant project is what we're calling the Oregon Poverty Measure. And this is using the standard official poverty measure produced by the census, which I'm not sure if you're familiar with the limitations, but sets quite a low threshold, has not been systematically adjusted since the late 50s. We know that life, the cost of living, and so on has changed quite a bit since then. And what we're doing is we're using a combination of administrative data from the state, DHS, and employment department, along with the survey data that generates that official poverty rate to create a more geographically nuanced understanding of poverty in Oregon and throughout our communities. Why are we doing that? We're doing that because a lot of the work, a lot of the examples we saw in the videos today, and frankly, a lot of poverty research is based on the urban experience of Milwaukee or Baltimore or Philadelphia. There's really a gap in our understanding about, especially along that suburban rural interface, which is what comprises a lot of the poverty areas of this county and a lot of counties in the state of Oregon. And so what we're hoping to accomplish with this Oregon Poverty Measure is a way to better understand the financial realities of people in these places that have been omitted and kind of left out of the discussion, hoping that's relevant to policymakers and practitioners, health providers, and so on. So those are two
Great.
things.
Thank you. And back to Dr. Schmidt. So for many people living in poverty, it's sort of like having an emergency every day, your own personal natural disaster. Can you talk a little bit about the emergency medical needs for people living in poverty?
Yes, but first I get to play the part of the
Pardon?
yes, but first I get to play the part of the politician and not answer the question that was asked, but answer the question I wanted to answer.
Great.
So just a couple comments. As you were
Please,
talking
yeah.
about food and the food bank, one of the things I realized I sort of wanted to say about Puerto Rico is the Puerto Ricans, as you know, are U.S. citizens, but are only partially treated like U.S. citizens, depending on what the government wants to do. And a fair number of years ago, they decided to cap the amount of food stamp money that they could get in the state or in the territory because, quote, they were spending too much money and it was costing us too much. They continued that after the hurricanes, and so both Texans and Floridians who were impacted by the storms got additional food stamp aid in the first couple of months to help them get through that. The Puerto Ricans did not. And there are multiple examples. 70% of Puerto Ricans have an insurance that's called Reforma, which is their equivalent of Medicaid. And it does not apply if they're flown to the continental United States and get treatment in any other state, and they have to separately apply for new Medicaid benefits in new states and are very limited in doing so. So that's the question that I wasn't asked that I just wanted to tell you about. And a little advocacy. So with that, I can actually answer and give you an example of the difference between being poor and having more resources in terms of the need for EMS. A number of years ago, and currently ongoing, we have a number of programs going on in the county to look at ways to better utilize ambulance service and better utilize emergency departments. And part of that involves what we talk about as community paramedicine, where people might be treated in their own homes for their condition, or they might be taken to an urgent care clinic rather than to an emergency department, or they might be scheduled for appointment. Many of those things are in progress, but a number of years ago when we were kind of checking on if that system would work, I happened to be riding with one of the ambulance companies' ambulances because I was their medical director, and we went into the home of a woman whose call for an ambulance was her child had a fever. Went into the home. It was chaos with 3 or 4 small children. I can't even remember how many because they were all running around in circles, literally. And she said she wanted to go to the emergency department because her kid had a fever, who was running around playing and looking as well as the other 3. I couldn't figure out which one of them wasn't feeling well. But nonetheless, our policy at that point was, if you want to take an ambulance, we'll take you wherever you want to go, to the local emergency department. So I said to her, we're going to take you to the emergency department, but I'm curious, why did you decide to call an ambulance rather than going to your doctor's office? Do you have a doctor? Oh, yeah, but it's a certain ways away. And she said, the last time I called and made a doctor's appointment, I took the taxi to the appointment, and when my husband got home, he beat me up because I spent the money. So that's one example. I think all of us could think of others. Again, if you live in a place where you don't have other transportation, you may be calling an ambulance literally because you need a ride and nothing more than that, whereas many of us would simply get in our cars and go, or make an appointment, or call an advice nurse. And as was mentioned earlier, even if it's a minor thing to us, anytime you call an ambulance, it's an emergency to the person who called it.
Thank you. Thank you very much. So we're learning about new ways to measure poverty, learning about ways that the EMS system is helping to interface with people experiencing poverty. Deborah, can you talk a little bit about what your organization is doing to tackle some of these complex issues? And if there are any steps that people in the audience today could take to make an impact?
Sure. Because we experienced a fire on July 3rd, we're completely shut down, which you can imagine is fairly devastating to our community. But as we rebuild and we come back, we're really looking at ways to provide the same services. Those aren't going to change. We'll always offer groceries and clothing and haircuts and showers and things like that. But we do really want to start creating education and places for people to learn how to build self-sufficiency. So for most of us in this room, when things happen, not unlike Dr. Schmidt alluded to, we would know how to take care of ourselves. We would get in our car, we would know who to call, whether a family member, a friend, or a doctor. But for most of the people that we work with, they don't have those networks. They don't have that resilience that most of us have. And so we're really looking to start providing a whole lot of education and workshops and just things, education to help people understand how to take care of their finances or parenting, job skills and things like that. So yes, come get some groceries. We want you to have healthy food. But beyond that, we want to really support people in ways that we've not done in the past. Wanted to, but didn't have the space. But now that we're redoing our building, we've got a whole lot of opportunities to take care of that. So we're really excited about being a little bit more supportive and not just providing basic needs, but really helping them with the resiliency and self-sufficiency of our community. And in terms of, I think, what people here today can do to make an impact is, there's a couple of ideas that I have. Certainly if there's an issue that you've heard about today or that you've been thinking about that's affecting the community, get involved. Reach out to your senators and your representatives when policy starts coming up. And the advocacy work it seems like maybe you're not making a difference, but you are. So I would really encourage folks to think about what you're passionate about or what you're thinking about and do some things. They're pretty simple and quick. I would also love for the stigma around poverty to change. I think it's really difficult. Part of the trauma for folks that are living outside or living in poverty is that they're stigmatized. And, so just really simple things. Always be caring and smile at folks that are suffering. I think even the smallest little moves like that, and talking about it with your family and friends. Because I think in this country we do criminalize the poor in a lot of ways, and I think there's some work that each and every one of us can do around that.
And Emily, similar question for you. Talk about some innovative strategies that the food bank is doing to help address these very complex and interconnected issues.
Yeah. Wow, Deborah, that was great. Thank you. Yeah, the food bank's working on a few things right now. I'll go through a few of them with you. One of the ways that we are addressing some of these issues is that we began our Healthy Pantry initiative. And basically what that looks like is just bringing in some staff who focus solely on nutritional education. And also bringing in healthier foods for our pantries. And so we have provided a large amount of produce for our pantries and for our partner agencies, and you can see the reaction in the communities. You can see people getting excited about healthy foods, and also providing those educational pieces for people to say, this is why we're providing this type of food for you. This is why we think it's important. And the reaction that we've gotten from the community is just fantastic. And seeing people reach for those vegetables and for those healthy, fresh foods that we're getting from partners in our communities and farmers in our communities, and just building those relationships is really important. And I think that's really directly connected with a lot of health issues that people are facing. And we've been working with the county as well on our Screen and Intervene program. And what that looks like is people going in and going to a doctor's appointment, and those doctors or those health professionals are screening people for food insecurity, and then they're right then and there intervening and saying, hey, you're screening positive. I want to provide you with these amazing resources in your community with the Oregon Food Bank. And just having that connection with our health partners is making a huge difference for people. And it's really great to see. And one final thing that I'd love to share that's really exciting, we are fortunate enough to have an advocacy team at the Oregon Food Bank, and they do a variety of really amazing projects. And so if you came in, you should have seen one of these little postcards. If not, you can grab one on the way out. Our advocacy team created these postcards to send to our senators. And we've done something similar like this before with paper plates. And we send them all in to our senators, and we say, hey, dear Senator Blank, this is why the SNAP assistance program is really, really important to me. 1 in 6 Oregonians and Washington residents are getting the fuel they need and getting the food they need because of SNAP. And if we cut those, we're going to see a really negative effect on these people. And so this is something you can do today, right now. I will take them with me back to the food bank, and we will send them to our senators. And I think this sends a really positive message, not just from people who are receiving SNAP, but from people in the community who are seeing the positive benefits of it and saying, hey, I'm not using this, but I know how important it is. Please don't cut this. So if you're comfortable filling this out and handing it back to me, I will bring it back. And I really appreciate you all being here and taking time to talk about this today. So thank you.
These are huge issues, complex, and it's so great to hear how each of us can do something, if it's as simple as acknowledging that person who's asking for money on the street with a smile and a look in their eye, donating, advocating with elected officials. There's so many ways that we can make a difference. We are now at the part of our agenda where we get to hear from the audience, questions from the audience. So I'm actually not exactly sure how this is going to work. So Philip or April, is someone going to be taking the microphone around? Okay, cool. So anyone who has a question, please raise your hand and we will get the microphone over to you. Any questions for any of our panelists today? Yes, gentleman in the uniform. Yes.
Thank you, the panel, for participating today. This is a really important topic. The three of us here work for Tualatin Valley Fire and Rescue, and we're on the front lines of the social system. And whenever it fails, people call 911, and we go. And that demand for service has been on a steady increase. I'm curious from the panel, through either research or your own experience, have you found a root cause and effective strategies that are actually making a measurable improvement on the problem that we're talking about today?
Just from the poverty measurement side of things, I just want to connect some of the dots here. So, for example, the SNAP program, the food assistance program, is lifting, don't quote me on the figure, but thousands, tens of thousands of Oregonians above poverty. So when we're under, for largely political reasons, discussions around cutting benefits that are existing, those are going to have a huge impact on the economic circumstances of families that are already at need. And we know that without those benefits, even more people will be in really difficult circumstances.
I don't have a direct answer to your question, but I have at least one answer. That some of the issue is the programs that treat emergency issues are fabulous and need to be there, like hunger and those sorts of things. But we also know that we need to get closer to the root causes. And for example, sometimes we make things worse, such as in Haiti, they provided a huge amount of rice and food subsistence to people. And as a consequence, the rice farmers were put into poverty because the rice prices went down because we didn't think ahead. And it would be much better to provide seeds for people to grow rice or to grow the crop. It's don't give somebody a fish, teach them how to fish. And so I think we do need to look at root causes and not just the superficial causes. That yes, we have to address the food emergencies when they occur, and they're incredibly important, but we need to think deeper.
You go first.
So root causes, is a really big question. I think that, well, we all know that hunger is not an isolated need. If someone's coming to our center because they don't have enough money to buy food, there's probably a whole lot more going on with them than that particular need. And so I think that there's some mental illness, there's addiction issues, there's lack of housing or what would be affordable housing. And then I think another root cause is the lack of jobs that pay a living wage. So solutions around that there's many, but they're hard to get at and they're expensive. But I think that there's a lot of root causes, what put people in those situations. And so again, I think it's looking at the whole person and really trying to address those issues. And for every person that's in need or that's calling 911, their solution and their root cause is probably going to be different. It's not a one-size-fits-all problem.
Yeah, this is a big question with lots of answers, and I think it can be overwhelming. Like the last woman in the video, or not the last woman, but one of the women in the video was talking about how homelessness is such a big issue, and there's so many root causes. And I think that just starting out by committing to knowing that there's going to be a lot of root causes and committing as service providers and organizations to working towards those root causes. So at the food bank, about 5 years ago, we started our new strategy 5-year plan, and we decided we were really going to work on equity and work on addressing the root causes of hunger, and that was kind of out of the norm. We kind of slid out of this charity model and started really putting ourselves in the positions of our clients and community members and holding them at the center of all we do. And so I think that's a good first step as an organization and as a service provider in an organization, is committing yourself to those things, and just acknowledging them and hopefully building off of that. And I know that's a very broad answer for you, but I do think it's important to do that and take it very seriously. I hope that helps.
I don't need a microphone. I just wanted to address your question. So I work in transition services for Department of Community Justice for Multnomah County, and most of my clients that frequently call 911 for services cannot access Ride to Care to go to the emergency room and have no resources in order to get either a bus ticket or a fare to go to the emergency room. So I think that if we can come up with another resource for clients that actually have no access to transportation to emergency services, while I'm working in conjunction with connecting clients with their medical home and building that trust so that they actually know how to access urgent care or primary care, I think we're just going to continue to see these increased numbers going to the emergency room. So my clients all use 911 on a frequent basis for everything as they're dope sick because they've used all their opiates and they can't refill their prescriptions. They've got a stomach ache in the middle of the night and they have to go see their PO in the morning, and the best answer to do is to go to the emergency room. So increasing trust with corrections, increasing access through our insurance so that they can go to the emergency room when they need to, when they want to, connecting them to their primary care home, building that kind of trust, I think, is one of the many ways that we can start mitigating this problem. And as a fellow Puerto Rican, I wanted to thank you for your work, and I feel like it's very, I am so moved at how much people do not know in this country what's happening in Puerto Rico. It is disgusting. And I just have to thank you for your work. And there is so much more work to happen in Puerto Rico. I have family that have not been able to communicate in 57 days still, and they have no electricity. And I think that's unfathomable for an American to have to experience that. So thank you.
Thank you so much for sharing your experiences. Woman in the white sweater there in the middle.
First of all, thank you for putting this wonderful event together. My name is Irrah Shriver. I'm the new medical director of Clackamas Volunteers in Medicine here in Oregon City. And I'm also new to this county, so this is actually a wonderful educational opportunity for me. My question is primarily for Deborah Mason. You said that there was a substantial, remarkable increase in the need, an increase that was over a short period of time. I think you said 20% in 1 year. Just building on the question that was just asked, I understand that part of this is probably for political reasons, but what concretely caused that increase in such a short time?
I probably can't say concretely what caused it, but our best guess is the housing crisis that we're in our area. The stat, and this is a federal stat that I'm hopefully not going to misquote, but for every $100 that rent goes up, homelessness increases by 12 or 13%. That's a huge number. Some folks in our area have seen way more than $100 increase on their rent. It's been 200, 300, sometimes doubled. And once you get evicted for not paying your rent, how hard or easy is it to get back into an apartment? And do you have first, last, and a security deposit? We have plenty of clients that live in tents and work full time. Granted, these jobs are at Jack in the Box, and they don't provide a living wage, but nevertheless, I think the biggest culprit is probably housing.
When I'm thinking about root causes and how to address those, I think about how there's very many different unique needs inside of different cultures and different populations. And I was wondering if any of you work at empowering the people you serve so that they could become mentors for others.
Peer support is really valuable, and I think it works really well. We've had some trouble incorporating those programs. We've got one going right now with a client volunteer group that's going through specific training. And what we're really hoping to do is to, through that program, identify folks that are ready to make their next move, whether it's getting back into the workforce, things of that nature. And so I think those programs are really valuable, and we'd love to do more. So we're getting started on that at our center, and hopefully leading to a job skills program. But it takes a while. Not everybody's ready to make that move, and if they are, there's still a lot of work that needs to be done for people that have been out of the workforce for a long period of time. So it's a process that we're going through right now and seeing some good results. Yeah.
Hi, I'm with the Immigrant and Refugee Community Organization, and one thing I was reminded when you talked about Jack in the Box. We're starting a new program where we take internationally educated nurses and prepare them for licensure and practice in the U.S. So while they live in poverty, they're working at Jack in the Box. They have master's degrees, they are well educated, they are well experienced, and there are so many barriers within our system that does not allow them to practice at the top of their license. And this is my first time in a nonprofit. I moved from OHSU, have been in Rwanda for 3 years, and coming to a nonprofit, it's heartbreaking. These individuals that I see who are really well prepared in many ways. Their English is not quite up to par yet, but the system itself is such a barrier. And how do we work? Not only these people are in poverty, but also have deep resources that we cannot claim yet because of some of the ways that we work our systems.
Who would like to take that? Any comments on the issue of immigrants and refugees and how that intersects with poverty?
Absolutely, there are issues with any chance of getting anywhere with the licensing boards. We've tried, and I don't think that is the mechanism. In fact, it's very hard to get from one state to another and get relicensed. But I think that people like that have great skills, and we need to look at ways to use them as health advocates, as translators, as cultural advocates, but we need to figure out a way to reimburse them for doing those things, and I don't know how to do that. That's the challenge.
Okay, go ahead.
Good morning. Thank you for this presentation. I'm the new executive director of the Oregon Oral Health Coalition, and I would like, if any of you could address, please, the issues of poverty and oral health, and why the integration of oral health and public, primary care is so slow in happening. Why, in all of the systems change that I hear you all calling for, there isn't a urgency about prevention and education in our system that could save thousands of dollars and help so many people get the care they need. Medicare, doesn't cover dental care for people over age 65, for example. So how can we work to integrate oral health and primary care when it's so correlated to poverty? So could you address that issue, please?
Hello. I can't really address the issue, but I can share some things that are happening. And I wish Michael Rawls should probably talk about the health clinics that are cropping up at some of the schools. They're doing some great work with oral health there. And I know in Clackamas County there are programs that are happening as early as kindergarten for oral health. So I think that's definitely a big push and the beginnings of seeing lifelong oral health starting with the kids. So I know that is happening in our county. But it is really important, and I can just speak from my experience at the center. Medical Teams International comes in once a month with their mobile unit to do oral dental care for us. But we all know that it's not just, it's a physical thing, it's also incredibly an emotional issue wrapped in our self-esteem and whatnot. So yeah, it is a big issue.
Along those same lines, it actually is one of the reasons that people end up in emergency departments and calling 911 because they can't get their oral and dental care any other way. And so they come to emergency departments because then they turn it into a medical emergency, which it sometimes is. And I think that this is an advocacy issue, that we need to change how we fund dental care and oral health and make it part of the primary care healthcare system.
We have a question down here, April, on the other side of the auditorium.
So you mentioned about peer counselors or peer support workers. I'm a public health nurse. Gail sitting next to me is a public health nurse. And going into a person's safe area, their home, whether they're, in the community, it seems like we are able to help them with so many barriers and hurdles that people go through, whether the previous person mentioned about transportation. They call, they don't get transportation. I call for them, they get transportation. That happens over, whether it's dental, whatever it is, a medical appointment. I call for them, they get an appointment. And I see that over and over again. And I know that we're kind of a dying breed here, and as we leave, we're not being replaced, and that's just the way of modernization. But there has to be a place for someone who can help people on a one-to-one, and really find those barriers for them and help people with just day-to-day needs, and not just give them resources, because I give people resources, I come back and they hit barriers, they hit a wall. So, yeah.
Navigating our complicated system. Anyone want to take that one on?
Thank you for being here. And I kind of have a loaded question, so I'm going to try to kind of understand it as I'm asking it. So last night I read an article by Willamette Week that said that homelessness is increasing at a rate that services cannot be met anymore, and people are actually being turned away from services and centers, and families are being put on wait lists. And they also said that it took about $3,000 to provide services to a family per month, while it would only take about $1,500 to, I can't breathe for some reason, $1,500 to shelter them in their own home. So my question is, and I work in resident services, so I understand that it's not just housing the family, it kind of takes an entire village to get them back on their feet and provide that stability and that structure. But this question is kind of for Deborah and David, but is it ever going to be possible to provide housing at half the cost, but then still provide services that's not exceeding the cost that we're putting in right now, and being able to reach those families so that they're not constantly going to the center and then being possibly turned away?
Well, one thing that, I don't know how to answer the question directly, but what I was thinking about while you were speaking was diversion. And that's something that we're thinking a lot about. So how do we keep people housed? How do we divert them from becoming homeless? So how do we support folks that are in need, that are struggling, so we keep them housed? And so in one way, I feel like what we do, and certainly what the Oregon Food Bank does, is we offset costs. And so if folks can get $60, $70, $80 worth of groceries, now that's money that's freed up to pay rent or to pay the medical bills or whatever it is that they need. So I do think that the work of diversion is really important, because once someone becomes homeless, the costs increase to support them. And to get them back on their feet. So what can we do as a community, as all the agencies represented here today, to keeping people housed? So I do think that that is something that we need to focus more on. keeping people in their homes. And I know that certainly government is working on that, Multnomah and Clackamas County, but I think that it's not just their issues. So yeah, again, just keeping people housed. So the support that is needed is not just groceries. It's not just free clothing and whatnot. It's really a whole support of the family unit and the people in need.
Thank you, Deborah. So oh, go ahead, sorry.
Do we have time? Yeah, okay. So I just want to say one thing, and not on the direct service provision side, but really about the role of government in this case. And I think that when we have an affordable housing crisis like we're seeing, this is the role of government to step in and offset what is really kind of a market failure that's happening in society. So it's not a direct answer to your question, but I think that as a collective society, I think we need to ask more from policymakers to step in where the market is really not creating a viable solution for people in the community.
And I just want to comment on a couple of things that came together in my mind. One is that TEDMED we saw about Seattle and their little backyard homes for homeless people. And then there was an associated story in the Oregonian on Sunday about actually a person that it turns out I know because it's the New Seasons I go to where he sells street roots, and the fact that he has a little home in a shed in Northeast Portland in someone's backyard just like this. And I think that maybe some of these tiny things are solutions, and that we need to think sometimes smaller rather than bigger. But it's going to be a challenge if people think that having a person in their backyard is a little overwhelming. And then lastly, to go with all of that, is a comment that comes out of Haiti, which is that although there are many people who have no place to live in Haiti, there are no homeless people, because the community takes care of people. And you see it all around, and it's something that we need to learn to do as a community, that homelessness is something that we've created in our community and we need to get rid of in our community.
So we're going to have to leave it there. Let's give our panelists another round of applause. I'd just like to thank you for being here today, for everything that you do to help people in our community live better lives. And with that, I will welcome up Don Emmerich, who is our Public Health Director.
Thank you, everyone. I have so many thoughts, and I'm a little overwhelmed by all of this. How many in here have multiple books that they start reading and they just can't get through, right? I have like 5 that I'm reading, and it's nuts. And I can't get through any of them. What's that? Well, thank you for that diagnosis. But one of the books that I actually started to read was the book called The Memo. Anybody know about that? It's called The Memo, and it's written by John Hope Bryant. And The Memo is really about financial literacy and how financial literacy is one of the key indicators of poverty as well. So I love listening to the poverty indicator discussion. And one of the things that he talks about is 15% of white rural America have a credit score below 620. 44% of African Americans in this country have a credit score below 620. And when you have a credit score of that, sort of that, at that low rate, you can't get homes. You can't buy a home. You can't get a small business loan. You are literally trapped. And so he really believes that this financial literacy piece, or the credit score policy, is one of the largest civil rights issues of our generation. It's a really interesting concept, and I don't think that's policy, right? That's policy, to think that a credit score that all of us take for granted. He also goes to say that no community in this country with an average credit score below 700 has ever witnessed or experienced a riot. Think about that. It's a very interesting concept that I would love to finish the book. So if you're interested, it's called The Memo. It would be a great contribution to this discussion. About a year ago, when we did this for the first year, Clackamas County Public Health introduced this concept called the health equity zones. And we've done a lot of work on that. We debuted this concept at TEDMED last year. And so to keep on this track, these are the health zones. These are the health equity zones. We heard a lot at the panel about how Clackamas is so different, and to have countywide policies are just not appropriate, and that our county is very, very diverse. And so we cut the county into these 10 health equity zones because we know that all of these thriving and very different diverse communities really do need different approaches. We know that Lake Oswego is a very different community than Oregon Trail, and North Clackamas is very different than Colton. So why should we have these one-size-fits-all approaches or policies per se? And so one of the things that we've been actually looking at, and I'd love to talk with you more, is looking at the layers of poverty within these 10 health equity zones, and how is there a correlation or a causation? It's not the same, but is there some type of relationship between poverty in these communities with health outcomes and just standard quality of life? And I think that the literature says that there is. And one of the things that we are looking at is tobacco. You know that the state just passed this past session, T21, which is a significant public health policy. And so every Oregonian here should be very proud that our state and our legislatures passed that. So tobacco 21. But what really actually comes with that is a policy that did not pass, which was the tobacco retail license. And tobacco retail license, really in its basic sense, is basically asking those who sell cigarettes and tobacco to be licensed so that we know how much is being sold, who it's being sold to, and so forth. And usually those two come together, but we only passed one bill and we didn't get tobacco retail license passed. And I'm happy to tell you that Clackamas County Public Health is taking on that at a county level. And it didn't get passed at the state, but we will be working to try to pass that at the county level. And here's why. So if we look at North Clackamas Health Equity Zone, the beauty of being able to do these health equity zones is that we can drill down into the neighborhoods of parts of the county. So North Clackamas. It's a little busy of a map, but I really want you to see this. This is tobacco overlaid with poverty, tobacco sales overlaid with poverty. And each of those green dots are retailers of tobacco. And look, I don't know if it's a coincidence, but if you look at the number of retailers of tobacco and where it's being sold, those dark lines in North Clackamas Health Equity Zone, there's a lot of tobacco being sold in our poor neighborhoods. The other thing that you see there, the little black dots, which I don't know whether you can see, that has a little flag on top of it, those are our schools. So this is where our children are. So there's an overlay between tobacco retail license, poverty, and access from our children. A very interesting opportunity here. So let's take another example. So that was North Clackamas. Let's look at Canby. Very different community. And so again, we can see the concentration of tobacco retailers in our most impoverished communities. The one thing that I'd like to mention is, and I asked this question the other day and I was just blown away by it. Tobacco retail licensing, as of right now, if you sell tobacco, you do not have to have a license, which therefore makes it very difficult for us to identify who is selling tobacco. So I'm hearing this, and then I'm looking at the maps, and I'm going, well, wait a minute. You just mapped them. What do you mean you don't know where they are? You just mapped them. And I didn't know this, but we actually had someone, it's before my time, 2 years ago, I heard that 2 years ago, one of our members of our health promotion team literally drove the entire county and documented and went in to every place. And this is the reason why we've been able to document. So unless you've had somebody who is that ambitious in your county government to go and actually document them, you would not know this information. And so we just really felt like it would be very important, given this topic, that we could share this with you and to know that everything is correlated. I mean, not correlated, but everything is integrated. Everything matters. That why is it that I could go through any of those other counties or those areas of the health equity zones and we could probably see the same layer, that where those communities or those pockets of poverty, that there's probably tobacco being sold. And so we look forward to working with every single one of you, as well as our elected officials, to hopefully pass tobacco retail licensing in Clackamas. And I think the data really makes a very strong case for that. And this conversation makes a strong case for that as well. The last thing that I will just mention is that there was a lot of conversation around solutions and root causes of this. Many of you, when you came in today, you had the opportunity to pick up the blueprint for a healthy Clackamas County. If you have one of those, hold those up for me. Beautiful. If you are not already involved in this, you can be, because this packet that you have in your hand, the blueprint, is part of the solution. And the oral health care, it was such a timely question. I don't have the answer for it, but one of the subcommittees that we have, the working subcommittees that we have in the blueprint, is discussing access to care as it relates to physical, oral, and behavioral. And that subcommittee is together to create strategic solutions to these problems of Clackamas County. So we may not have a solution now, but we're hoping that that subcommittee can certainly do that. And I do know that we have some oral health advocates already serving on that. And if that is an interest to you, you can certainly participate on that subcommittee. All right. Thank you.